Sure, go ahead. Thank you.
Okay.
All right. Good evening, everybody. Thank you all so much
Go ahead.
for
Thank you.
joining in to the third of our webinar series. Oops, excuse me. Third of our webinar series, the Cannabis as an Alternative research study results. So tonight, I'm very excited to be here on the third of 3 webinars where we'll be discussing cannabis as a harm reduction alternative and some policy recommendations. So tonight, I'm joined by 2 very esteemed legendary colleagues, Dr. Peter Grinspoon and Andrew D'Angelo. And I'll get into their introductions in just a second, but very excited for an interesting and lively discussion tonight. So again, good evening, everybody. My name is Dr. Marion McNabb, and I am the president of the Cannabis Center of Excellence. We are a 501c3 nonprofit organization that's based out of East Boston, established in 2018, that works to bring together policymakers, researchers, cannabis consumers, patients, and others in the industry to collectively conduct research studies, document best practices. So the Cannabis Center of Excellence organized this webinar series in part as a result of a research study that the Cannabis Center of Excellence completed last year. That research study was looking at cannabis as an alternative to other more harmful substances. And so this is our third of the webinar series. If you missed the first 2, the first one we held on April 9th, where we actually presented the results of the research study. The second webinar, Peter and I dug into what were the clinical implications of the findings for these research studies, from this research study, and talked a little bit more about some clinical recommendations that are found in his book, Seeing Through the Smoke. So if you've missed the first of our 2 webinars, we'll be dropping links to the YouTube in the chat. And we hope that you'll join in and watch those previous webinars. So tonight, here we are at the third one, and excited to be digging into policy implications as a result of these research study results for not only Massachusetts, but for other states. So I want to acknowledge our webinar series sponsors. A big thank you to Green Lion Partners, Caroline's Cannabis, and Holistic Health Group for the support to make this webinar series possible. And thank you to Talking Joints Memo for being our media sponsor. We will also be dropping in the chat some of the previous articles from Talking Joints Memo, and also a big shout out and thank you to Cannabis Science and Technology magazine, who's also been very generous in supporting coverage of this webinar series. So for tonight's webinar, we're going to shift it up a little bit. I'm going to introduce our legendary OGs that I'm joined with here tonight. And then we'll flip into, I'll present some very brief results from the research study to ground us. And then we'll present the policy recommendations that have been developed and submitted to the Governor Healy administration last month. And then we'll dig into a lively discussion with Dr. Grinspoon and Andrew about the specific recommendations. So, and move into live Q&A. Just a few notes about this webinar. This webinar is being recorded and live streamed to YouTube, and it will be posted on the Cannabis Center of Excellence website in the future. We hope that this will be an educational resource for folks in the future to access freely. Feel free. We want this to be a lively, interactive Q&A, which is why we're doing a Zoom meeting. So for folks that are in the Zoom meeting, feel free at any time to drop questions throughout the chat. In the chat throughout the presentation, and we'll work to answer those questions in our discussion. So now turning in, I'm very excited to introduce our 2 speakers or experts tonight. One's Dr. Peter Grinspoon, and my co-partner in this webinar series and very dear friend and good friend. Dr. Grinspoon is a primary care doctor at Mass General Hospital, an instructor at Harvard Medical School, and has been a cannabis specialist for 25 years. He is a prolific writer and educator around medical cannabis and is also a life coach. And most recently published his recent book, Seeing Through the Smoke, Cannabis, an Expert Doctor Untangles the Truth About Cannabis. And we dug into that book last last webinar series, Peter. So I'm going to hand it over to you. Maybe give yourself a little bit of background for our audience.
Oh, sure. I've been involved in this issue probably about as long as our other guest Andrew has, like forever. And first of all, my dad was a cannabis specialist, Lester Grinspoon. So I grew up with it, people debating or advocating for legalization in my living room. And then secondly, when I was growing up, my brother Danny fought an unsuccessful battle with childhood leukemia. But my parents procured him cannabis in the early 1970s. It really helped him keep food down, maintain his weight, really made him a lot more comfortable for the last year of his life. So I've been interested in cannabis as a medicine for my whole medical career. I've been treating people with cannabis for about 25 years now. And I spend a lot of time trying to educate doctors about it. And this is really interesting to see how doctors are evolving on this issue. They're much less against it, and a lot of them are much more open to it than they used to be. It seems to change like almost every day. And I think part of that's because of these great webinar series that Marion runs. So glad to be here.
Thanks, Peter. Thanks for doing these series with me. And thanks for all your leadership and work in the industry. Next, turning to Andrew D'Angelo, a true OG legend in the industry, who co-founded Harborside, which is one of the first medical dispensaries in California and the first medical dispensary to introduce lab testing. So thank you for that. And also is the co-founder of the Last Prisoner Project, a really wonderful organization that's working to get people incarcerated for cannabis out of prison now that we are in the legalization movement. So really honored to meet you and for you to be here tonight, Andrew. You are a trailblazer in the industry and the founder of Andrew D'Angelo Consulting. So I'll hand it over to you to share a little bit of your background.
Well, thank you, Marion. Wonderful introduction. Not too different a background than Peter. My older brother, Steve, is about 10 years older than me. He was involved with, as a cannabis entrepreneur and activist. So I grew up with it in the living room. I also, on my mom's side of the family, my mom is one of 8 siblings, or was one of 8 siblings, and the other 7 siblings all passed away from drink or drugs. So I went to a lot of funerals when I was a kid, and this issue was very personal to our family. And also, when I was working in the underground cannabis community, I saw a lot of issues with addiction as people self-medicated to deal with sort of the stress and trauma of being underground or getting arrested and being incarcerated. So it's something that I've taken a keen interest in. When we opened Harborside in 2006, we were one of the first licensed dispensaries anywhere in the world. And there was still a tremendous amount of stigma, even in California. And one of the first things I noticed from our patients, particularly patients that were taking a lot of pain medication, was that they were able to reduce their pain medication. And in some cases, completely get off their pain medication using cannabis as a substitute or even an alternative, really. And that's when the light bulb started going off in my brother and I's head. And that's one reason we wanted to start a lab. And that's one reason we wanted to engage science as much as possible to try to figure out what's going on here. Because cannabis is a lot less harmful than as a pain reliever, because a lot of these folks that we were seeing were in chronic pain, mental or physical. And, the efficacy, the safety of cannabis is one of the safest substances somebody can put in their body. And we saw a lot of potential in those early days. Since then, not a lot, but some science has happened. Great leaders like Peter and Marion and others have really leaned into this. And we're starting to see more studies and I hope more clinical trials involving cannabis and addiction.
Yeah, amazing. Thank you for your leadership from the very beginning. It's really incredible. And, just to hear that you've had those stories happen, it repeats, the findings that we found in our research study. So back in 2023, in August of last year, we concluded this cannabis as an alternative research study. The idea was to ask cannabis consumers and patients, are you using cannabis to reduce some kind of other more lethal or more harmful substance? So anything from opiates to alcohol to tobacco to other prescription drugs. And then we also asked people to take the survey if they weren't cannabis consumers, but they were interested to learn about how cannabis was being used as an alternative therapy. And here are just some of the summary results. Again, if folks missed the first webinar, we went into great detail about all the research results. So I encourage you to go back and watch that. But as you know, some of the key findings from our study last year was that 23% had reported using medical cannabis to reduce the use of opioids in the past, just as you said, Andrew. 41% were actively using cannabis as an alternative therapy or treatment for their health conditions or symptoms. Nearly 60% of our sample reported actively or using medical cannabis in the past to reduce alcohol use, 62% with tobacco, and 84% reported using medical cannabis to reduce the use of substances or mitigate the withdrawals of substances. And again, 53% of the non-cannabis users reported that they have a desire to learn more about how cannabis can play a role in harm reduction. So as a result of these study results, as we know, there's a growing opioid epidemic in the United States and in Massachusetts, and there's opportunities for really trying to consider education and, research around this topic. More recently, states thankfully to our Governor Healy, who led the nation in suing the Sacklers and other pharmaceutical giants related to the opioid epidemic. And now, as a result, there are millions of dollars in opioid resettlement funding that is across the United States that's really working to address the wrongs and the raging opioid epidemic. So I think just now, this is a great opportunity to start to really destigmatize the role that cannabis can play. And as a result, we have developed some policy recommendations. I know this is a sort of a busy slide, and we will be putting the recommendations in the chat. But I'm excited to switch over to discussing each one of these recommendations with our panelists tonight. But in summary, the recommendations 1 and 2 are focused on educating healthcare providers, developing training materials, and educating healthcare providers at all different levels about the role that cannabis can play, the risks and the benefits. The third recommendation focuses on the idea of possible donations of medical cannabis and programs, and I'm excited to talk about that one a little bit later. The fourth is conducting a cost savings assessment of introducing cannabis as a harm reduction alternative at a state level on costs for addiction and recovery. And then the fifth is really to further explore research around this area. So I'm going to stop here and we're going to move into our discussion time about these recommendations. So very excited to kind of drill in one by one. And ask our panelists, what their thoughts are. So the first one is around funding the development of an evidence-based training program and education materials for healthcare providers, recovery workers, and frontline workers on the evidence, role, and risks of medical cannabis as a harm reduction alternative. So understanding both educate healthcare providers and other workers, I'm curious what your thoughts are about this recommendation, about the role of educating healthcare providers, what you might recommend for mass, and if this new announcement around rescheduling will have anything to do with or in support of training healthcare providers. So maybe I'll start with you, Peter. What do you think about the role of educating our healthcare providers and frontline workers?
Well, I think it's absolutely critical. I think that medical students, residents, doctors at every stage of their career are very hungry for good information about cannabis. I think that, what we've been taught in medical school and to a certain extent in the medical literature, now it's a little bit more mixed, but it's been very negative and not very helpful. And then, when you look at the fact that at this point, 94%, according to some polls of Americans, support legal access to medical marijuana. It's a huge gap in like sort of the patients know more about it than the doctors do, which is really kind of awkward and not helpful. And then, when the doctor doesn't feel comfortable, they can kind of shut down the conversation, and then the patient doesn't even mention it to their doctor. And that's like completely unhelpful because, the safest thing is to have open discussion between the doctor and the patient so that they could talk about like medication interactions and the way it can affect other drugs and stuff. The only problem that I'm facing with sort of contributing to this kind of unified education of doctors, nurses, healthcare providers is that there isn't like complete agreement on the pros and cons of cannabis yet. And that makes it really hard to establish sort of a protocol or like a training manual or guide or clinical expectations. What I've found is that for example, doctors, like what a doctor thinks about medical cannabis depends a little bit on his or her vantage point. On the one hand is the oncologist, like it's hard to find an oncologist that isn't pro medical cannabis. Like they see their patients, kind of like my brother Danny, like benefiting with like nausea, vomiting, anxiety, pain. And something like 90% of oncologists are in favor of medical cannabis. And on the other end of the spectrum, for example, are like the pediatric or adolescent psychiatrists who see the very rare but tragic cases of like young person smokes a ton of cannabis, develops bipolar or has a psychotic episode. And, it's unclear to what extent the cannabis is contributing. The cannabis isn't blameless, but these are pretty rare cases, but at the same time, they're very tragic. And so the psychiatrists and the addiction people tend to be very against cannabis. Your average doctor, say your primary care doctor, like I do and my colleagues and friends do, like 2/3 of them are in favor of medical cannabis. And this is all shifting in the right direction. People are becoming open to it because they're seeing that their patients are doing well and their patients are just telling them that they're doing really well. But it is difficult to come up with training in something where there isn't consensus. Like we all know that penicillin treats strep throat. So we could teach medical students use penicillin if someone has strep throat. But if the addiction people or the psychiatrists are saying cannabis makes anxiety, depression, PTSD worse, and the cannabis doctors are saying cannabis can make anxiety, depression, and PTSD better, it makes it very confusing for people and very difficult. So I think a huge part of this is going to be all of us finding a way to find common ground. I mean, I think that people can agree that cannabis is bad for people with psychosis and good for people who have chronic pain. I just think there is a lot more common ground in this issue than we all give ourselves credit for. And I think cannabis, given that so many people are in favor of it, I think cannabis could be an issue that unites us rather than be one more issue that, we beat each other senseless about. So I'm hopeful, but it is a little bit difficult when there's sharp disagreement about what the harms and benefits are. Sorry, that was kind of a long answer. So.
Yeah, no, it's a great answer. And it's interesting because I recently participated in a Delphi study that was looking to gather consensus around competencies of medical cannabis education, both for nurses. Yeah, so, and I think, there might be lots of groups. I think you're absolutely right. I don't know what you have seen, Andrew, if there's consensus around this topic or what your experience is.
Well, consensus is a hard thing to develop around cannabis, even within the cannabis community. It's it's a complex plant. It has a complex history. It has a complex pharmacology, and it has 100 years of prohibition, stigma, and lies attached to it. And all of this has muddied the waters of transparency, knowledge, and consensus quite a bit. So it doesn't surprise me. What I can tell you is in 2006, when we first opened Harborside Health Center, there were only a handful of doctors that we could send people to get a recommendation. Most of the doctors scoffed at the idea of medical cannabis. Most of them would not, even those that perhaps supported medical cannabis, didn't want to take on the reputational risk with their non-cannabis patients to write recommendations. And so today in California, almost 20 years later, throw a rock and hit a doctor that'll write a recommendation, basically. And so while progress is very slow to somebody who's suffering, or activists and advocates like me and you, Marion, and Peter, and it can be so frustrating. in the aggregate sense of things, we're making tremendous progress quickly. When we first opened Harborside Health Center, I don't think there was a single medical school in the country that even taught people about the endocannabinoid system. Now, I think, Peter, you know this better than me, but there's a bunch, right?
Well, more every day. And it always amazes me that all of them don't teach the endocannabinoid system. Even if you hate cannabis, you need to understand the endocannabinoid system because it
Yeah,
controls everything else. So we're getting better, but we still have a long ways to go.
right. And this is how you develop consensus, right? It's not behind walls, it's through glass. And you have to be transparent. And you know, the study that the Center for Cannabis Excellence did is super important data that when I saw it, it confirmed all my anecdotal knowledge of this issue. But I was struck by the numbers. I mean, the survey in California, 2,800 people, 97% of the respondents said that of the respondents that were opioid either dependent or prescribed, 97% of them said that cannabis was helping them reduce or eliminate. That's just a number that will get anyone who's into data, who's a medical professional, it's going to get their attention. I mean, I think the positive outcomes for 12-step recovery programs was it 30 to 50%, something like that.
I think it's like 5 to 10% personally, because
5 to 10%.
they only
Yeah,
keep track of the people that keep coming. They can't keep track of the people that they never see again. So that sort of
right.
beats their numbers. But
Yeah, so not a great percentage compared to some of the numbers we saw on that survey. And anyone who looks at this with intellectual honesty, certainly through a policy lens, right? You got to follow the numbers. You absolutely have to, or you are committing a malpractice, really.
Yeah. What do you think? I mean, with the new announcement with the DEA and the rescheduling, I'd love to kind of stop and hear both of your insights about that and where that stands and might that play into addressing the opioid epidemic with cannabis. You want to start, Andrew?
Sure. I'm not a big fan of Schedule 3. I want this plant to be descheduled altogether. I think that's going to create a lot more access and a lot more faster road to consensus. I think when you have Schedule 3, it may be more. First of all, Schedule 3 is not a done deal, everybody. There's a long process of comments and administrative hearings and litigation that is going to take place, and all of those judges and courts are going to impact what happens with rescheduling. Hopefully, we can get those courts and hearings to deschedule. So the battle's really on now that the public comments have opened for advocates to make our case and to cite the evidence and there's a tremendous amount of evidence to support descheduling. I think more so than supports rescheduling. So that's what I would like to see happen. Is it a step in the right direction? It's hard for me to say enthusiastically yes, but it's also hard for me to say definitively no. So it's for the first time one agency in the federal government declared cannabis a medicine. Another agency at least approved the recommendation, although the DEA has not recommended rescheduling yet. We should be very clear on that. They are holding their cards very close to their chest until the process is done. They have the final decision after the administrative hearings are done and the public record has been examined. They could decide to keep it in Schedule 1 or drop it down to Schedule 2. So it's another chapter in the long journey to normalization and ending prohibition. But I'm very curious what Peter, as a medical professional, thinks about Schedule 3 from that viewpoint, particularly with research and science. I've heard mixed things, Peter, about whether this makes it easier or harder or about the same. I don't know.
Well, first of all, I agree with you completely about descheduling versus rescheduling. I mean, tobacco kills 500,000 people a year, and people don't realize this, but last year there were 172,000 deaths from alcohol. And it's crazy that those two are descheduled and the cannabis is just going to be Schedule 3. I do agree that it's a step in the right direction, at least in symbolic value. At least the government's admitting again, it used to be illegal medicine until they criminalized it in 1937. But again, the government's admitting that cannabis is a medicine. And I think that it takes away some of the stigma and makes it easier. Some of my older patients, like someone in their 80s, are like, I wouldn't touch medical cannabis, even though my kids are telling me to take it for my arthritis. And I think it's going to be easier for people like that to kind of get started on it because there's going to be less stigma. I don't think anybody really knows what's going to happen with the research. What I've heard is that, as it is now, a lot of the research is based on like surveys because you can't really get good cannabis to study because it's all from that crappy farm in Mississippi. I guess it's lightening up a little bit. And, it's also just very onerous to like, you have to like lock it up and you can't travel with it. And it's very difficult to do research. So a lot of the research studies are like these questionnaires. They ask 1,000 people to use cannabis, and then are there differences in this or that? And those aren't very accurate studies. So what I heard is that maybe it'll make it more possible to actually give people cannabis. Actually the cannabis people are using, not this crappy pseudo cannabis they get from the DEA. The DEA are good at, hounding people, but they're not very good at growing marijuana. So it'll be good to actually, and it's just weird that, like, for example, in Massachusetts, I could drive like 5 minutes down the road and buy this beautiful cannabis, but we're not allowed to test that on patients. So I think with Schedule 3, it's going to be easier to actually give people cannabis and see, does your blood pressure go up or does it go down? Actually see what the effects are on people. So I think it's going to open up research some, but I completely agree that it's sort of incoherent to have it be Schedule 3. I mean, Schedule 3 is like really restrictive. That's like ketamine and like Tylenol with codeine and anabolic steroids. And it's also like, who's going to try to get it through their doctor? You'd have to like find a doctor that wants to prescribe it and then, see if your health insurance will actually pay for it. They try not to pay for anything. And then see if the pharmacy will give it to you when more than half Americans just go out and buy it. And then the other half, unfortunately, just get like Delta 8 or something online because it's really available. I don't think it's not going to really go through Schedule 3 ever. So I agree that it's sort of incoherent. It's sort of a symbolic step in the right direction. And that hopefully we're on the path towards descheduling, which would have taken a little bit more political courage. And then the one question I have that nobody seems to be to answer is, is this going to make it easier for patients to use cannabis in the hospital? Because now it's not a forbidden Schedule 1 substance, it's still illegal. But the hospitals are worried about losing their federal funding. And it's hard to sleep or eat in the hospital anyways. But imagine if you're on cannabis every day and then you can't use it anymore and you're having withdrawal. It's like a nightmare. So I'm hoping that, as the government lightens up, things just get a little bit easier for medical cannabis patients.
Yeah, I mean, you're both making excellent points. And I think the thing also from my perspective around Schedule 3 is how is that research funding or how is that being locked into a potential, a larger pharmaceutical industry interest or, and the ability to take that. So one of our colleagues, Shalene Title, she's a former cannabis control commissioner in Massachusetts, and she runs the Parabola Center. She just published yesterday, they did a survey, of what folks think about who's creating cannabis policy. And I just pulled it up because she posted this today on social media. A new study conducted by Parabola and RTI shows that more than 2/3, 67% of American adults trust people with lived experience to make cannabis laws. Less than a quarter trust tobacco, alcohol, or pharma executives to make cannabis laws. And by lived experience, I'm assuming she's referring to lived experience of, cannabis. And I know it's just quite interesting, like of who then it is. And I'm sure both Andrew had a lot of experience in understanding the polar sides of the cannabis industry and these.
Yeah. Well, I could tell you that nobody that is in the decision-making level of public policy is engaging me to help them make public policy. And I've made myself available to all kinds of stakeholders, including in Massachusetts. And, you know, in the very early days of the Massachusetts program, the elected officials didn't really support the program. They had to do it because the voters approved the program. It's much different in Massachusetts now. You have a lot more political support than you did in the beginning. But good public policy, I think that study by the Parabola Center is spot on. It confirms what leaders like Peter and I and my brother and a whole bunch of smart activists and entrepreneurs and I've been saying for years and years, you can't make good policy if you don't know anything about this plant, its history, the people that use it, grow it, transport it, sell it, consume it. That's where you want to draw your expertise from. That community is where you want to draw your expertise from. Doesn't mean we have to be running for office and being the elected officials ourselves, although I hope more and more of us will do that, that those that have that competency and skill set, because we need as much representation as we can get. But just to be, you know, around the table so that we're not on the plate. And I think that that's super important. So those that are listening and are in public policy, you know, Peter's available to help. I'm available to help. We can both introduce a whole bunch of other experts from the cannabis community, people like Marion, people like Shalene, that can really, really help develop policy. The Parabola Center has policy after policy after policy they've already developed, they've already written down. They can training that they can give policymakers on, you know, how to create an equitable and fair ecosystem that will, one, take care of patients, because increasingly in these adult use frameworks, I'm sure you saw the same thing in Massachusetts, patients feel left behind by the adult use framework. They really do. And there's good reasons for that. A lot of their products change, a lot of their brands change, a lot of their providers change. And it's very disruptive to them. And then we also seen the influence of just corporatization of the cannabis industry, and the displacement of smaller and certainly equity participants that took care of themselves and their families for generations and decades in the legacy market, and now are quite displaced. So so all these folks are available and ready to contribute to public policy. And I think if we can just collaborate more with folks that do that every day, we'll have better policies. I think all of us can admit that the policies name a state, and you can find serious flaws with the public policy with respect to cannabis.
Yeah, I agree. And, you know, I think, and having, you know, people like what you were saying, patients feel left behind. I definitely, you know, we see this in Massachusetts with the rise of the adult use industry. Absolutely. There's been renewed push, you know, to think about how to de-verticalize the medical industry to make it a bit, you know, less hard to get in on the medical cannabis side. But there's still a lot of work, and to promote patients, a lot of work that still needs to be done. One of the things that I've seen, and this kind of turns us into our third recommendation, is, you know, sometimes patients who are on disability or who are really suffering have low income and, you know, really can't afford the full supply of medicine, and especially if they're at higher rates. So our third recommendation, and I'm very curious to hear if this is a good one or not. I'm going to put in the chat right now, and it is surrounding about reviewing options for developing regulations that support donations for medical cannabis for people who suffer from addiction to alcohol, opiates, and other harmful substances. And I know you have experience, Andrew, with a program, a donation program in California that this recommendation was based off of. And we've been talking about, you know, promoting this sort of pilot project or approach here in Massachusetts. We've also talked about there's a pilot project in Illinois, and we covered this, Peter, in our last webinars, that where you could take your opioid prescription and walk into a cannabis dispensary and get cannabis instead of opioids. So I'd love to hear both of your thoughts, pros and cons for this. You know, what are some things that Massachusetts could consider?
Well, I'll tell you. Oh, go ahead, Peter. Go ahead.
Oh, yeah, well, just I think it's a great idea. I think it really helps people with suffering from different addictions, not just opiate addiction, but from alcohol addiction. And um, I mean, I think donations are a really good idea. There's no reason not to do them. And it's just, you know, medical cannabis can't be another treatment just for the well-to-do. It has to be available to everyone. And, you know, poverty is a real risk factor for addiction. You don't have to be poor to be addicted. I was addicted as a doctor, so it can really affect anybody. But the thing is, I think in addition to donations, it's really important that health insurance pay for it because a lot of people are in really fixed incomes, not just for addiction, but a lot of people with chronic pain. I mean, there's so many veterans and so many older Americans that are just in really, you know, they just get a certain amount of money every month, and it makes it very difficult to afford medical cannabis. And there's not a reason in the world why the insurance companies aren't paying for medical cannabis. Study after study, including our study, but many other studies have shown people use fewer opiates, fewer benzodiazepines, they drink less, they use less tobacco, and they use less Ambien, all these medications that are not only have harms and are generally more harmful than cannabis, but also are very expensive for the insurance companies. So there's really no reason for the insurance companies not to be bearing some of the financial burden. So I'd like to see that as well as donations. And just as a case in point, I had a patient. I work at an inner city clinic in a very poor part of Chelsea. You know, a lot of immigrants. About a third of my patients even speak English, and I was able to transition someone off of both Valium and Percocet, and they were doing great. They were doing so much better for their pain and for their anxiety. But then after 3 months, they were like, "I have to go back on my Percocet and my Valium. The medical marijuana cost me $150 a month." I mean, in Chelsea where I work, that's like $1 million. And you know, on Mass Health, the Percocet cost $1 a month, and the Valium costs $1 a month. So they were spending $2 a month instead of $150 a month. So the financial incentives have to be there, and I think donations really good in that it kind of fixes the holes in kind of our safety net. But I'm very eager in getting the whole safety net fixed so that people ideally wouldn't even need donations. They could just, you know, their health insurance would pay for it.
Yeah, yeah, and
Right.
go ahead, Andrew.
Well, I think Peter's absolutely right. If you had Social Security, if Medicare and the insurance companies and the VA, okay, covered medical cannabis, the donation program would not be as large a need as it is right now. What I'll tell you, our experience in California, when we opened Harborside Health Center in '06 under the medical framework, there weren't any regulations on donations. So we could give as many donations as we wanted to, as long as we were under the limit that a patient could have every week or every day. And growers were more than willing to donate product or sell us product at a much lower rate to our collective. They were also part of our collective, the growers. And it was an amazingly effective program. So effective that we had to put a cap on how many people we could give the medicine away to because it was a cap of 1,500 people a month. No, 1,500 a week, which is 6,000 a month. And largely, a lot of that was due to logistical issues that we had just managing all those people coming in. And those were people, you had to show that you were in poverty to participate in the program. It wasn't a high barrier to entry. You had to show us that you were under public assistance. You had to show us unemployment, food stamps, something like that. You didn't have to fill out a whole bunch of forms. There wasn't a lot of red tape. We were a dispensary. We wanted to do this. We were not worried about diversion. Okay, we were not worried about the poor people taking the free medicine and then going and selling it because they're poor people. So like if they need to trade or sell, we weren't too concerned about that because number one, we knew 98% of the folks were going to take it themselves for the same reason Peter just said. They really got benefit from the medicine. And if there was a little diversion, we didn't feel it was going to be that harmful to society and to the world. Then when the adult use program came in 18, they banned it. The state banned the donation program because they were so worried about diversion of product, which I know Massachusetts has been very worried about since their program launched. And all the regulators are worried about it, and law enforcement's worried about it. And so we had to pass a new bill in California. It took us 4 years to pass a bill, and the bill got watered down a bunch of times. And now what you have to go through to get the cannabis to give away is there's a whole bunch of hoops you have to go through. A dispensary can't give it away directly like we were able to do. We had to source it from, now you have to source it from a manufacturer or a farmer. It has to come into, you have to have a special event that you invite all the people to. You have to make sure, you know, everyone's a patient or everybody is in need, or so there's just a lot more red tape involved in getting the medicine. So whatever Massachusetts decides to do with this program on a public policy, learn from California, make it as least restrictive as possible. Don't worry about diversion, worry about access, because for every day you don't have a program like this in the state, there are people turning to the Valiums and the Percocets, and there are people that are perhaps overdosing. There are people that perhaps have cancer or are recovering from chemotherapy, can't access cannabis, can't afford it. And insurance doesn't cover it. There's no donation program. So it's a very important plug in the system right now. And we managed to get it back up and running in California. But if not for the compassion, the willful compassion of basically caregivers, it would not happen out here right now. It is happening in certain places on a limited basis, but we did not get it right the second time. We got it right the first time. So I hope that Massachusetts can look at that and act accordingly.
Yeah, thank you. Is there any like reports or anything? And maybe we can follow up on that so that we can share those with our lawmakers here. But you both bring up very excellent points about health insurance. And I just put our fourth recommendation into the chat, which is to conduct a cost savings assessment of introducing cannabis as a harm reduction alternative on state costs to addiction and recovery. And also really could be thought about from health insurance perspective. I do know that New York is making moves around because of the very high costs of addiction and recovery. They are thinking about introducing, medical cannabis coverage just to reduce that high level state budget, of what it means to keep these people on treatment. And so, yeah, I think there's really an important and interesting opportunity to do that. I really, and to also, to think about this donation program has come up here in Massachusetts several times for the veterans studies and work that I've done as well. And that's where we've tried to, at least, like you said, for certain populations, either be able to low barrier, easy access, and the VA should really also be considering.
Right. In Canada, the veterans get an allocation of cannabis. Why couldn't they do it in Canada and we can't do it here? There's like no reason for it.
I'm so glad you brought that up because I just put that as a note. Yeah. That Canada, literally, you as a veteran,
You get like 3 grams. What is it, like 3 grams a day or something? I can't remember the exact amount, but
yeah, it's pretty significant. Yeah, if Canada can do it, why can't we do it? All right, so we've only got a little bit more time. We've got, a couple more minutes here on our webinar. And we got our last and final recommendation, which is really around implementing a research project to understand the scope so it's implement a research project to assess the scope of medical cannabis as a potential harm reduction alternative in Massachusetts. We've already talked a little bit about the difficulties of studying cannabis. You mentioned, Peter, there's survey, based work. I know, Andrew, you're involved in some research studies, maybe, and have really played a strong role in supporting research. So I wonder what you all think, now in Massachusetts or just statewide, should we be really digging into this, and specifically from a research perspective?
Well,
So
I would
what do you-
say,
Go ahead.
I would say absolutely. Look, I think if I read the report correctly, you have about $500 million in settlement funds in the state of Massachusetts from the opioid settlement. Is that right?
Yep.
That's a once in a lifetime chance.
Mhm.
If we look back at the tobacco settlement funds, I don't think they were used very well. I think they were squandered, a lot of them. I'm not an expert on that topic, but as the opioid settlement funds have come into being, I've read a lot of media reports about the tobacco funds not being used right. So it's really a once in a lifetime opportunity to use those funds to do research, to not just give people methadone, right? Don't just take $500 million and put it into methadone. Let's be innovative. Let's do some research. Let's get some medical cannabis going. Maybe get a little bit of psychedelic therapies funded. Because if 12 steps is only 5 or 10% effective, and we have a crisis, it only makes sense to use some of those funds for this purpose. There's going to be a lot of stigma about using opioid funds for yet another drug. But I hope that the leaders like Marion, like Peter, and I'm happy to help, in Massachusetts, can kind of cut through that stigma, because I think if you can fund this research, again, this is anecdotal evidence from all these folks I've talked to and all the things I've seen and Peter have seen, but this is a powerful harm reduction tool. It is going to save lives and it is going to save money, for the state and for insurance companies and for the feds and for the healthcare system overall. That you're talking about a medicine that somebody can grow on their balcony, if need be, or hopefully access really not in too difficult a way. And so when we have data that supports, wow, this really is a powerful harm reduction tool, then it can be used more widely as a harm reduction tool. And some of that data can be then used to develop the consensus that Peter was talking about in the beginning, because a lot of the medical professionals that work in recovery in particular, not a big fan of medical cannabis or even psychedelics. I mean, the heated debates I've had with that community have been pretty intense. So if it did nothing else but lower the stigma and get that community more engaged, with at least opening up their minds to this possibility, then that in itself would be a pretty big win right there. So I'm a big supporter of this, and again, the settlement money's there, and hopefully you can access some of it.
Yeah, and it's across multiple states as well. And I think there are unique programs that each state, could implement as well. Peter, what are your thoughts?
Well, I agree with what Andrew said. I would also just add that, you need the data to bludgeon the insurance companies to paying. You need the data to, convince the skeptical doctors. And you need the data to get, the hospitals set up to provide this care. And, I know so many people that have used cannabis to help with different addictions, but, they're all doing it on their own. And it would be so great if we could study like what's a good dose and, what's the best delivery method and how can we use this to help with opiate withdrawal and does cannabis work as well as opiate as Suboxone or methadone to prevent overdoses, or is it better if we just use it for pain, for anxiety, for insomnia, and for withdrawal symptoms. I mean, I think people do really well on their own, but we could do so much better if we were studying this and had sort of a coherent, sort of rational way to approach it. So I'm really looking, if this is going to happen. It's just a question of when. It's already starting to happen much more than has been happening. I mean, to study cannabis over the last 50 years, during the war on drugs, you had to show that something was dropping, IQ, sperm count, motivation. You had to show some harm. And now I think it's opening up more. And I'm just really looking forward to not only having more tools to help people, but also to understanding how to help them better and to understand what it can't do as well. I mean, as it is now, the people who are against cannabis, still use these derogatory quotation marks to talk about medical marijuana, like the American Medical Association, and they need to be much more open about like the benefits. But also, I think people who are real advocates for cannabis can be very skeptical about harms because the government, frankly, has lied about it for so long. But it's like for anything, for any medicine, there are benefits and there are harms, and there are like better ways to use it and worse ways to use it. So I'm looking forward to like both sides in this debate. Again, it's all about common ground, how we could all move forward. But I just think the pro-cannabis people have to understand that it does have some harms, and we need to understand those. It doesn't mean it's bad or should be illegal or should be disdained. It just means that you want to be smart about it. And the anti-cannabis people have to understand why, more than half of Americans now have tried cannabis. Like there are 50 million people in this country with chronic pain, and it really helps them. So I just think that the data is going to help sort of help us walk through a lot of this disagreement and help us get to this common ground that we need so that we could make people more comfortable and just feel more valued and better taken care of.
Yeah, I agree with both of you. Recently, I would say this is probably a couple years ago, a study came out that looked at, I think it was in Science magazine, that looked at what were the funding sources around research for cannabis around the United States. And the US is the largest funder of research that was intended to show harms. And over like 90% of the research publications that were out there or funding that was available was really to show the harms. So to your point, having balanced, we need to know what the harms are, but we also need to have funding to know what the benefits are, and to have a balanced conversation around this. And to your point, Andrew, I think, Peter, you've also had a lot of arguments with the addiction and recovery community around that. I myself have too here. We have a strong community of addiction recovery in Massachusetts that, and you make a very good point that are primarily against it, but you make a really good point. If we can, conduct studies locally, show local data, and show that there is real value that people, and not only collect quantitative data, but I think, people's stories, and qualitative data and experience is really important to look at here. So, okay, we've got 5 minutes left.
I just want to say for the record, not all the addiction people are against it. I know a lot of really cool addiction doctors that just realize that like people use it and it helps them and they want more data too. But it just, it's always like the sort of the anti-cannabis quote unquote experts, the ones that seem like they are talking about a different drug. Those are the ones, they're all addiction people and they tend to be against it. But your rank and file addiction doctors, I think, are really coming around because, they don't want people to be miserable. And I think that they're starting to question a lot of what they've learned about it too. So again, I genuinely think we're getting there.
Great. And I think, yeah, probably providing more targeted evidence-based education programs. Our first two recommendations would be of help there. Cool. So I'm going to ask our speakers one last piece of advice for Massachusetts in this area. What would you tell our policymakers, or what would you tell the Governor Healy administration?
Well, I'll start. I just say that there actually is a lot of common ground about cannabis, both in the harms and the benefits. There's a lot of things we don't agree with, but there is a lot of common ground. And there's certainly enough common ground that it helps with anxiety, pain, and insomnia. And those are three things that fuel addictions. Like everybody who's addicted has anxiety, pain, and insomnia. So I just think that whether or not we get to the point of using cannabis like Suboxone and methadone, like as a medication for opiate use disorder, it's really the humane and compassionate thing to do is to make cannabis available and accessible either through donation programs or through health insurance paying for it. I think it can save lives. It can make people more comfortable. It can make them less. Like when you addicted, you lose everything, and it could give people hope again. So I just think it's no matter what, it's going to be an essential component of how we treat a whole range of addictions. We just don't know exactly how to best use it.
Yeah, my advice is we haven't talked a lot about the difference between state policy and local policy. In California, just take one program, one policy, the new donation program that I described has a bit of red tape. At the local level, there's only a couple places you can even do it. Because the state allowed the local people to decide whether or not the program should be implemented or not. Don't do that. The local people will default to no a lot. We've seen that in Massachusetts all over the place with respect to both medical and adult use framework. So if we're gonna fund research, if we're gonna set up a donation program, if we're gonna try to use cannabis as a harm reduction tool, if we're going to do a pilot program for insurance coverage or whatever it might be, make sure it's integrated throughout the state and at the local level, and that veto power is not given to the local folks because it's hard to get consensus. And then if you finally get at the state level, but only 2 communities in this state say yes to it, we haven't done a good job. So and you might have to work outwards from the local to the state in terms of developing consensus in order to sort of avoid that problem. But I would hate to see sort of that same issue rear its not too pretty head with respect to the difference between state and local control.
I really appreciate you bringing that up because it's extraordinarily important. And in Massachusetts, local control is very it's a thing here. And
Well,
so
here in Massachusetts, like a lot of the white wealthy suburbs, like banned these dispensaries. And then, the prohibitionists were like, aha, look, the cannabis industry is targeting, black communities. And it's like, no, nobody's targeting anybody. It's just how the white communities opted out. It's so ridiculous. So
yeah, and it's a very important point too with the resettlement funding, because the resettlement funding, there's state level funding, and then the majority of the funding is actually at the local level. So to actually provide services. So there's the cannabis, and it's the same local local either city councils or the local political bodies that license the cannabis entities are the same political bodies that are approving how to use this funding at the local level. So I'm really, really glad you brought that up, Andrew. It is a very big deal here. So I want to thank you both so much for this really lively, excellent discussion. I think it's a very important, timely time for us to be chatting about it. And yeah, just to really appreciate your time and your collaboration on this topic. We're about at time. So I would like to let you both let the audience know how they can get in touch with you in the future and stay in touch.
well, sure. For me, it's just go to my website. It's www.petergrinspan.com. And I've got a contact me button, which just goes right into my regular email. So if anybody wants to contact me, just go into my website, shoot me an email if they come up with any questions.
Awesome.
I'm the same, andrewdangelo.com. Contact me button goes right to my email. You can also do info@andrewdangelo.com. That's another way. But please reach out. Love to hear from folks.
Awesome. Yeah. And if anybody would like to stay in touch with the Cannabis Center of Excellence, if you liked this content, you can reach us at www.cannacenterofexcellence.org. We just launched a very affordable annual membership. So if you're interested in this kind of content and what we've been working on the last 7 years, you can go on and be able to find a whole new resource and data and information that's been made available by our very dear partner, Keefe Studio, who powers the back end of our website. I'm very grateful to Gibby's Garden for the support to make our new website possible. So visit us, you can join us, become a member. If you liked this content, you can consider giving a donation. That'll help us do future webinars about similar topics or additional topics. So again, thank you, Peter and Andrew, so much for the time and the great conversation. And I hope everybody enjoyed our talk.
Thank you, Marion, for pulling it all together.
Thank you, Marion. Thank you, Peter.
Thank you,
Pleasure.
Andrew.
And thank you, everybody, for having me.
Yeah, awesome. All right.